In the overall STS database, in a more recent study of almost 1 million patients, about 700,000 on pump and about 200,000 off pump, we recreated the same curve we'd found at Emory University many years earlier. And that is to say, with low-risk patients, there was no benefit from the point of view of mortality of off-pump surgery. And the greater the predicted risk, the greater the relative merit of off-pump compared to on-pump. But it matters how you do this operation. And Borgerman, in Circulation in 2012, really drove that point home, arguing that clampless off-pump bypass was state-of-the-art. And I have to say that one of the many bad mistakes that we made in trying to popularize off-pump bypass was doing it with a partial occlusion clamp on a pulsatile ascending aorta and expecting a lower stroke risk. It's only if you avoid that clamp on the ascending aorta that the stroke risk will go down. And this was shown really dramatically by Dr. Borgerman and others in 2012, with the relative risk for death, stroke, or death or stroke of about 0.3. Remarkable benefit. And this is a Polish meta-analysis of the impact of relative degree of manipulation of the ascending aorta. And basically what we found in this meta-analysis in 2016 was that the less you touch the aorta, the lower the risk of stroke. And there's a reason for that. David Taggart and others way back in 2007 explored transcranial Doppler of the middle cerebral artery during proximal anastomoses performed with a side-biting clamp or various non-clamping facilitating anastomotic devices. And he found many more solid microemboli in the clamp group than in the non-clamp group. So we use routinely this device. It's called the Heartstring device. Many of you are familiar with it. I joke in New York City, working for Mount Sinai Hospital, a Jewish institution, that it looks like a yarmulke, and you roll it up into a burrito and put it in the aorta, and it pops open into a yarmulke again, and then you sew the anastomosis and pull it out. What it allows you to do is to create a proximal anastomosis on the ascending aorta in a relatively bloodless field with minimal aortic manipulation. Not zero, but minimal. We always very carefully identify the optimal spot for this anastomosis using the epi-aortic ultrasound. So again, in 2015 in JDCVS, this study of strategies to reduce stroke, no pump, no aortic clamp. That's the nutshell. If you can go from a facilitating anastomotic device instead of a clamp, or from a facilitating anastomotic device to a no-touch technique, you reduce the observed to expected ratio for stroke. Edelman in 2012 looked more explicitly at anaortic OpCap versus side-biting OpCap, and anaortic OpCap versus conventional CABG. And again, the less you manipulate the aorta, the lower the risk of stroke. David showed this study done by Michael Ballally and colleagues. We're pleased to be co-authors on this important study, summing to about 37,000 patients in a meta-analysis, looking at dividing the patients into on-pump conventional operations, off-pump with a partial clamp, off-pump with a Heartstring, and off-pump with a no aortic touch technique. And this is the way I like to look at these data. There are other illustrations in that paper, but I can understand this one much more easily. For the endpoint of stroke, comparing anaortic OpCap to conventional CABG, the stroke risk is reduced by almost 80%. For mortality, anaortic OpCap compared to conventional CABG reduces mortality by 50%. Myocardial infarction, anaortic OpCap is similar to a Heartstring OpCap and has an odds ratio of MI compared to a routine CABG of 0.7. Also for bleeding, for atrial fibrillation, dramatic benefits of avoiding aortic manipulation and the atheroembolism that can come from it. So how do we do this? This is one of the ways with bilateral IATA and left radial artery. That is our default operation. I would say that 80+% of our coronary bypasses are done this way, with double mammary harvest and left radial artery harvest. Usually we can get the job done with just those 3 arterial conduits. Occasionally we take a vein graft as well. We can use that radial artery in a variety of configurations. If you're going to do this, you have to be very careful about the relative competitive flow and the outflow limbs of that composite conduit. But it can be applied across an entire department. Dr. Sargent talked about implementing off-pump and no aortic touch techniques in Belgium. Here is Alexander Albert's very recent report in JDCVS of implementing a no aortic touch all arterial process at his department in Dusseldorf with impressive reduction in stroke, especially early stroke, reducing it to 0.25% as he ramped up to 100% aortic upcab. And again, aortic upcab in his patients was a striking predictor of reduced stroke risk, and it was predominantly an early stroke, not the late stroke that may be due to atrial fibrillation. So I would summarize by thinking about upcab now that it can be better than ONCAB, but requires special expertise. I think we've done a lousy job in teaching it. Dr. Sargent is our last best hope in getting it right. Clampless no aortic touch OPCAB by minimizing or avoiding manipulation of the aorta is associated with lower risk of stroke and especially benefits higher risk patients. We know that beta prolongs life and radial arteries are usually better than veins. We know that DAPT is important, especially for off-pump graft patency, especially vein grafts. I think that all arterial no aortic touch OPCAB, or at least no clamp OPCAB, is state-of-the-art CABG, and it's becoming increasingly clear that not every center or every surgeon can do it. Having said all of that, you can see that off-pump bypass in the United States of America has gradually declined over the last 10 years and now comprises less than 15% of all cases. So I'm switching gears now to talk about a new therapy that I am cautiously optimistic about in highly selected patients, and that is hybrid coronary revascularization, a combination of surgical and percutaneous techniques, intentionally and scheduled in 2 different coronary territories. I'm going to show you 2 quick cases. The first is 2-vessel disease, low syntax score with proximal LAD stenosis and a mid-right coronary lesion in a patient who refuses sternotomy. He's a Jehovah's Witness. This is his proximal LAD lesion. You can see here, I've seen it getting better here in the coronal view, and then a type A lesion in the right coronary artery. So this is the OR setup, full monitoring. This is the robot shown here away from the patient. The patient is anesthetized here in preparation for single lung ventilation. The robot console is down here. We insert trocars in the 2nd, 4th, and 6th intercostal spaces and then dock the robot, insert the camera and instruments, and then the harvest of the internal mammary is accomplished utilizing the robot rather than under direct vision. So this allows us to harvest the mammary with no thoracotomy and certainly no traction on a thoracotomy. The instruments, for those of you who aren't familiar, are about the size of a pen and have 6 degrees of freedom, so they really do allow us to see very well and operate very well in a closed chest environment. So I've been actually very fond of this procedure. It's eminently doable to harvest a very good quality internal mammary pedicle without opening the chest. As you probably know, this is a telemanipulator, not a true robot. It has no autonomy. It only does what we do with our hands and feet. And ultimately, once the mammary is harvested, we heparinize, clip the mammary, tether it to the pericardium, and then divide it. And we back out the robot, undock the instruments, back it away, and then use a long needle and a robotic camera to identify the optimal site for a very small incision, typically 3 or 4 centimeters with minimal rib spreading, to identify and stabilize the LAD with a Nuvo device, and then suture the lima to the LAD under direct vision. You can see the scale of that incision looking at my fingertips. It's small. Anastomosis is conducted exactly as you would do in an open operation with complete visualization. We always measure the flow in the grafts, as I think Dr. Arai would give us a passing grade on this one. Good flow, low pulsatility index, and good diastolic fraction. The next step is to inject the internal mammary graft and then stent the right coronary artery. You can see a very nice result from this. Second case is a the first was a Jehovah's Witness. This one's a left main case. A similar young gentleman, a laborer, refuses sternotomy and has just distal left main and proximal LAD stenosis. You'll note both of these cases are typically cases that would have been managed routinely by multivessel PCI. They're not typically cases that get referred for coronary bypass grafting by sternotomy anymore. Here's the angiogram showing distal left main bifurcation and proximal LAD stenosis. The right cornea was clean. Again, another view of the distal left main. We did a robotic Lima LAD harvest and grafting to the LAD, and then subsequently PCI the left main into the circumflex. Here's the injection of the IMA to the LAD on post-op day number 1. And now here's the stenting of the left main into the left circumflex with a drug-eluting stent. Short, large stent, a single stent. And with the completion angiogram, it shows a beautiful flow from the left main into the circumflex. The patient went home on day 3 and back to work in 2 weeks. Here's his chest a month post-op. So pretty darn good result in a patient with limited coronary disease, not typically referred for CABG. So here's the present trial that we're working very hard to enroll in. This is the NIH Hybrid Coronary Revascularization Trial, or hybrid trial. We're rolling it out through North America and Europe at this present time. The purpose is to evaluate the safety and efficacy of hybrid therapy versus multivessel stenting in patients with multivessel coronary disease involving the LAD and/or left main. And again, these are typically patients that are treated with PCI, not CABG. We have a big task to enroll 2,300 patients and randomize them to having Lima LAD with PCI of non-LAD lesion or multivessel PCI, following them for 5 years to assess the primary endpoint of death, stroke, MI, or repeat revascularization. And this is a superiority trial, powered to detect a superiority of hybrid over PCI. Inclusion criteria: patients with multivessel disease involving the LAD and/or left main and at least one other epicardial vessel. A single LAD lesion involving the takeoff of a big diagonal is also a qualifying anatomy for this trial. Routine exclusion criteria. Hybrid is defined as off-pump minimally invasive sternal sparing Lima LAD, and that was our original goal. However, we have recently expanded it to allow sternotomy off-pump Lima LAD in centers that can do that reliably and are not equipped or skilled at off-pump mid-cap. Primary endpoint again is MACE, death, MI, stroke, and repeat revascularization in 5 years. These are the secondary endpoints, including, importantly, ischemia-driven revascularization and cardiovascular mortality. So that's a great trial. We're very excited about it. We're working very hard to get enrollment going, but the reality check is that about 1% of coronary bypass in America is done robotically at the present time. So we heard a few moments ago the importance of medical management. I think that Dr. Park, the other Dr. Park's talk on the importance of medical management in CABG patients was really a brilliant lecture. This is a paper from Kurlansky and others in Circulation 2016, looking at about 1,000 CABG patients and about 2,000 PCI patients in 8 community hospitals, focusing on their medical management after discharge. And here you can see CABG and the effect of aspirin use on MACE. For CABG patients who got aspirin versus didn't get aspirin, is a remarkable difference in MACE at 5 years follow-up. Similar lipid-lowering agents improved survival of CABG patients compared to those who did not receive it. So that really gets us back to my final thought. The beginning and final thought is the heart team. If we're going to get the indications for surgery and PCI right and get our patients treated with optimal medical therapy, we have to do it as a team. There's no other way to get it done, and in keeping the patient's interest at heart. The ideal coronary heart team includes an interventional cardiologist, a cardiac surgeon, and the non-interventional cardiologist, all working with and thinking about the patient. Stuart Head wrote this very interesting paper in the European Heart Journal back in 2013 talking about the importance of a heart team in stable coronary disease. And I think you've seen this slide before from that paper, demonstrating how dramatically different the CABG to PCI ratio is in multiple different developed countries, without any good explanation for why that would be. And even within the United States of America, the rates of CABG and PCI vary dramatically. This is per 100,000 population. This is not a population map of the United States. It's a map of CABG per 100,000 or PCI per 100,000 patients. So it's a dramatic variability across the United States of America. And when you look at different papers describing the appropriateness of PCI or CABG in different countries of the world, the variation is dramatic, from an inappropriateness rate of 1% to 43% for PCI, and an inappropriateness rate for CABG of 1% to 43%. So dramatic variations from guidelines-directed therapy on both sides. So this emphasizes the importance of the heart team approach, which has been ensconced as a Class 1 recommendation in our guidelines, and the calculation of the syntax and STS scores to guide that conversation. So in conclusion, and this is my second last slide, I think there are it's a three-step process in my mind and at our coronary heart team meetings. We assess the coronary lesions by syntax score. We assess the patient's comorbidities and operative risk by STS score, and by that important surgeon's eyeball assessment of the patient, which is imperfectly captured in the STS score. And then we make a recommendation based on the guidelines and on patient preferences. My personal bias, I think we do way too much PCI in young patients who will benefit from multiple arterial conduits. And I think we do too much CABG in frail elderly patients who meet the guidelines for CABG, but frankly may be better off with an incomplete revascularization by PCI, given their various comorbidities and operative risk. So in conclusion, I think the future of coronary surgery is a continuous evolution. We can see from the various trials that have been discussed so very well today that CABG is superior to PCI for most patients, especially diabetic patients with complex disease, but stroke remains the Achilles heel of CABG. I think we can worldwide adopt epi-aortic ultrasound scanning and Doppler graft assessment as a routine and improve the quality of work we do. There are numerous grafting techniques that can avoid or minimize aortic clamping, and those should be routine, whether you're on or off pump. A single clamp on pump must be standard, and clampless off pump bypass should be the routine for the off pump surgeons. Arterial grafts generally last longer than venous grafts. They should be used routinely whenever appropriate, and I personally am very outspoken and feel very strongly that a second arterial graft should be a quality metric. If the STS won't step up and do it, I would encourage the cardiology governing bodies to do so. We should certainly do so in our own institutions. Medical management after CABG is important, and it's been woefully ignored. There is much room for improvement in how we perform both on-pump and off-pump CABG. I think that to get there, though, we have to genuinely focus on CABG because it is the most technically demanding procedure that we perform. I think we need to establish reference centers for state-of-the-art CABG, and within each cardiac surgical center, there should be designated surgeon or surgeons who specialize in doing CABG at a state-of-the-art level. The goal should be a zero mortality and, frankly, a zero stroke rate in elective CABG. Thank you.
Thank you, Dr. Pukas, for your comprehensive review and excellent presentation. You already told us the future CABG, but I would like to ask a little different question. So, we are living in AI, in the era of AI, artificial intelligence. Since the advent of AI, the doctor's role and the treatment paradigm, especially cancer treatment, had been changed rapidly. So you think the cardiac surgeon's role also will be changing? If so, what should we prepare for in era of AI?
I'll be brutally honest.